and welcome to this edition of the Rural Doctors Programme. I'm Jerry Gannon, and once again, thanks for your company. In this programme, we're going to take a look at headaches, but first, I wanted to take a moment to remind you about one of the services Rural Health West provides. Outreach in the Outback aims to improve access to medical specialists and multidisciplinary health teams for rural and remote towns and communities. This project for Rural Health West is supported by funding from the Australian Government Department of Health and Ageing. By delivering health services closer to home, Outreach in the Outback services are currently being delivered in communities in Western Australia. As a health professional, you have the opportunity to provide a valued service to Western Australian, rural, remote and Indigenous communities. Rural Health West needs support from medical specialists, general practitioners, nurses, allied health professionals and health organisations to make a real difference in Western Australian communities. Your skills, experience and expertise are needed to provide quality, accessible care in rural and remote towns and communities. If you're interested in taking part in Outreach in the Outback or would like further information, please contact the team on 6389 4500 or visit us at outreachintheoutback.com.au for further information. Now, Dr. Olga Ward is joined in the studio by Professor Tony Celenza, Head of Emergency Medicine at UWA, Dr. John Salmon, Pain Management Specialist, and Jane Muirhead, Occupational Therapist. They're going to discuss the management of headaches and migraines, as well as red flags to look out for when dealing with more serious headaches.
Well, good evening and welcome to the program.
Hi, Olga.
Good evening, Olga. Could we start by talking about the thing that scares country GPs perhaps more than anything, and that is the sudden, acute, severe headache that presents to your emergency department that you think might be something that might kill your patient. And I guess this is Tony's main area of expertise. Tony, headaches are common. What shouldn't we miss?
Well, in terms of diagnostication, you mean?
Yeah.
Yeah, so the things that we look for are the red flags that most people know about. And that includes the thunderclap headache. So this is the sudden, severe onset headache. Any headache which has evidence of raised intracranial pressure, any evidence of meningism, any evidence of focal neurology or seizures, any headache associated with trauma, and any headache with an older patient. So they're sort of the more obvious ones. And then when you examine the patient, again, you're looking for those sort of features. And when I examine someone with an undifferentiated headache, and the severe sudden ones scare me too, I sort of try and divide them into the intracranial causes, which might be primary or secondary, like migraine and tension versus bad intracranial causes. Then I look at the local causes, so is it cervicogenic or is it TMJ or ears or sinuses or eyes? And then I look for systemic features. So have they got a viral illness or have they got any other form of sepsis or drug interactions or drug side effects? So that's how I sort of do my diagnostication.
And if you've got a patient with a sudden severe headache but no really focal signs, how do you treat when you're not quite sure what's going on?
Well, we treat them symptomatically in the first instance, and a lot of patients do have a background of headaches, and so it might just be an exacerbation of their chronic headache or a recurrence of a severe chronic headache. But if it's a new onset headache and it sounds like something sinister, and the most sinister one that we would look at is subarachnoid hemorrhage, then we would treat them as such. So we'd treat them symptomatically. So we'd give them pain relief, antiemetics if they're required, IV fluids, which often is a good treatment for headaches. And then once they're stable and comfortable, then we'd investigate them.
Mm-hmm. And are narcotics a suitable kind of analgesia, or do you tend to go for a different group?
Well, it depends on our clinical suspicion. So if we think it is a sinister headache, and so it's got those other features that I mentioned before, then if the patient requires narcotics, then we'd give them some opioid medications. So we'd normally give them titrated IV morphine. Mm-hmm. If our suspicion is not that it's sinister, but it's a severe benign headache, then we would probably treat them as a combination headache, because often you'll have someone who may have a migraine type headache, but then it gets combined with a tension aspect as well, because you get a migraine, you don't feel well, you get tense, you get a tension component, and you start to vomit, and you don't eat very much, so you get a dehydration component. You don't sleep very well, so you get a sleep deprivation component. So we tend to treat them sort of as all of those things combined. So we give them some IV fluids, which helps non-specifically with headaches. We'd give them some phenothiazines often for a migraine component, and we'd give them some simple analgesics for the tension component.
And how effective is that?
Very effective most of the time. There are a few patients that require an escalation of their analgesia, but most patients will improve with a single dose or a couple of doses of phenothiazines.
So this is something that you would maybe just admit them overnight in the observation ward and just simply run some obs and run an infusion, and they go home in the morning feeling good?
Yes, or even earlier. So some patients have a very quick response. The ones that often have a classic migraine pattern, and they think it's a migraine, you think it's a migraine. Often some IV fluids and some phenothiazines, some prochlorperazine or promethazine or chlorpromazine, any of those.
Yep.
Over a few hours. Often they have a bit of a sleep and they wake up and they feel much better.
When we're going through drug side effects, as in, long-term medication side effects, you quite often see in the small print benign intracranial hypertension. Does that produce an acute headache or a chronic problem?
Well, I just see the acute presentations, but often it's on a background of an escalating headache. So it's something that is quite rare, and so it's not easily diagnosed because the features aren't often classically diagnosable.
Yep.
And then they present because they're not tolerating the headache anymore.
So is that something that you see, John?
Very rarely, I would say. And I think usually with pressure headaches there's a relationship to posture and Valsalva manoeuvres, but I believe it can be quite subtle in its presentation and can present quite late with neurological symptoms and signs.
Yeah. Certainly when you're a student and a resident, people say to you, you must have a look at the fundi, which of course is quite difficult in a photophobic, pained patient. But how subtle is the papilledema in something like that?
Well, I've only seen a couple of cases which have had papilledema that I could see.
Yeah.
So it is unusual to see it, either because you're not looking for it or because there are other features which tell you that this is probably the diagnosis and you're going to need to go on and image them or do other tests.
Yeah.
And so looking for papilledema should be done, but often it's difficult to see it. If you don't see it all the time, it's difficult to interpret what you're actually seeing. And it might not be the clincher, because if it's not there, it doesn't exclude the diagnosis.
No. And do you treat that just simply by withdrawing the precipitant, like withdrawing the minocycline or whatever it is that they're taking that's causing it?
Yeah, it depends on the precipitant, and it depends on how severe it is. Because if they're starting to get neurological sequelae, then you have to lower the pressure. So you might do something a little bit more extravagant, like doing
like
lumbar puncture. Yeah, but otherwise, if it's just the headache with no neurological complications, then yeah, you can just withdraw the precipitant if you know what the precipitant is.
How often do you do lumbar punctures for headache patients?
As a diagnostic, on a daily basis, because where I work, it is the neurosurgical centre. So we tend to, I don't know how, but we tend to attract a lot of patients with complex headaches. And so we do screen for severe, sinister headaches on a daily basis. As the neurosurgical centre, we do tend to attract a lot of patients with brain tumours. So we scan a lot of patients with headaches, and we have a high pickup rate for sinister causes. And we often will LP patients to exclude subarachnoid hemorrhage or meningitis, but less likely to do that.
You have to be careful about lumbar puncture with raised intracranial pressure, don't you?
That's
and
true.
coning, so
Yes.
you have to scan them first, and if in doubt, refer on to a neurologist before doing the lumbar puncture.
Well, yes, and it depends on what you're doing it for, because a CT, it's just an association, and the CT may not actually tell you exactly how raised the intracranial pressure is. So if someone has, if we're doing a screening, if it's for subarachnoid, we always get a CT first, because that might be positive and give us the diagnosis, then we don't need to do an LP.
Yep.
If the CT is negative and the patient is well, then we'll do the LP. For meningitis, it'll be similar. We often get a CT first because it's readily available for us, and that's to exclude other causes that we might see.
Yeah.
But if you're in the country and you don't have access to a CT, I would think that if the patient has near normal mental status and no focal signs and no raised intracranial pressure signs, so no papilledema, then it's probably safe to do an LP if you need to do a diagnostic LP.
Yeah.
But on the other hand, if you think
you
it's
can always
meningitis,
put the manometer on there anyway.
you could, but then it might be too late. But most of the times it'll be for meningitis, and you probably treat them empirically anyway.
What about headaches in pregnancy and postpartum?
I don't really deal with that very much. In my experience recently, we've had a couple of cases of late pregnant patients who have had headaches and have had poor outcomes. So my practice is, if I've got someone who's in late pregnancy with a headache, I assume it's PET.
And treat all the other extraneous things and fluids and calcium and magnesium
Magnesium, yeah. So if we've got someone with a headache, even with a normalish blood pressure, we'd probably get
antihypertensive.
get the blood pressure down, magnesium, call obstetrics for an opinion.
Alpha methyl dope is still used for acutely lowering blood pressure like that, or do you use something a little more
I don't know.
onset?
I tend to use hydralazine, very carefully if I need to do it, or just magnesium, which can lower blood pressure. So I would start with magnesium first. It's got a number of other useful benefits in PET.
How do you deal with patients who chronically present with what they describe as acute severe headache, but that you suspect are drug seeking?
Well, first of all, the philosophy is that, generally our philosophy is that if you're not sure that they're drug seeking and they seem to be in pain, it's probably better to treat
the pain.
But there are patients that we know are seeking. And so if we think that there's a migrainous component, we'll treat them as a migraine, which means that we don't give them opioids. And if they persist and want to go onto the opioid stream, then if it is an exacerbation of chronic pain, then we probably would consider some oral opioids if we think it's appropriate for that patient's clinical circumstance. If we think that they're truly drug seeking, then we'll just tell them that, and they'll go.
Well, speaking of migraine, quite a lot of patients complain of migraine, and what they have seems to be either a mixed type of headache or maybe a non-migrainous headache that is just a little bit more unilateral. How do you really tell?
Well, migraine is a common condition. It affects about 17% of females and about 6% of males. And any recurrent hemicranial, usually headache with nausea, vomiting, photophobia, doesn't have to have all those features, is likely to be migraine. And tension headache is usually a milder recurrent headache that isn't disabling. And the important thing is to diagnose migraine because of the specific treatments that are available for migraine. And that's the key thing in preventing patients who are becoming recurrent, who are presenting with severe recurrent headaches and seeking opiates, is to put in place effective preventative treatment. And it's very underutilised, preventative treatment for migraine. So if patients are having more than 2 or 3 episodes a month that are not responding to triptans and to the usual acute analgesics, they should be considered for migraine prophylaxis. And there's a list of drugs which we can supply. The thing to start with, I think, is amitriptyline, starting at a low dose, 10 milligrams 2 hours before bed, and adjusted in the dose range of 1/2 to 6 tablets is usually sufficient. Adjusted to give nighttime sedation, but avoiding a dose that causes daytime drowsiness or other side effects. And then if that's not effective, you can try propranolol, and then Topamax is probably the next one to try.
I'm not familiar with Topamax. What is Topamax?
Topamax is topiramate, which is an anti-epileptic drug, which has been shown to be effective for prevention of migraine and is helpful in chronic migraine. And the dose range is up to 200 milligrams twice a day.
Yeah. And is that something that's accessible to GPs, or is it something that you're prescribing off PBS indication through a pain clinic?
No, it's on PBS now for recurrent migraine and chronic headache.
Now, some of these headaches present, and you're not quite sure, or they seem to be a mixture of tension and
Well, tension
and
headaches can actually turn into migraine headaches. And that's a whole different ball game for self-management as well, because you know, if people can manage the headache before it becomes migrainous, often there are ways that they can perhaps abort some of those migraines happening. But I don't think that's always recognised, that, you know, a chronic tension headache can, for some people on a fairly regular basis, turn into a migrainous headache with the nausea. Not so much the aura, but the nausea certainly, and the debilitation that brings about. So, yeah.
So then they end up having symptoms of both. But Tony, you were saying you can treat both together.
Yeah, often you may not need to actually make a diagnosis of one or the other, as long as you have excluded the other sort of secondary causes of migraine, of headache, because you probably have people at one extreme that have, you know, pure tension, and those that have a pure migraine. But I think most patients are in between and have components of both. And there's some evidence, well, actually quite a lot of evidence, which shows that treating them as migraine resolves both components. So there was a study that looked at Maxilon, metoclopramide, pethidine, a mixture of both or neither, so placebo. And they started off with pain scores of 8 out of 10, and after 45 minutes of Maxilon and pethidine, their pain scores went down to 15. And this was both those diagnosed as migraines and those diagnosed as tension headaches. And the differences were exactly the same. So obviously most patients have a combination of them. And placebo was effective as well.
Pethidine has a really short half-life, yeah? 2 hours?
Yes.
Is that enough to turn off a migraine?
Well, that study showed that Maxilon was better.
So just give the antiemetic.
Yeah, it doesn't lead to a rebound headache, because pethidine wears off and then you haven't actually fixed the problem. Whereas Maxilon lowered the pain scores more, and there's less likelihood of rebound. So you might as well just give the Maxilon.
Just before we leave that acute setting, some patients present just with the aura before the migraine. They think they're having a stroke, or they might be having a stroke because they've just got, you know, sparkly bits in their vision or whatever. Can you actually turn it off then? Yeah,
and that's where, you know, triptans or ergotamine can work. We rarely use them in the ED because most patients have tried those and they work best in the first hour. And most patients don't get to us in that time. So that's why we use the phenothiazines. But if you get it early enough, then triptans are probably the most effective that you could try acutely.
Good. Is aspirin indicated in those cases?
You can use a simple analgesic. There's no contraindication to it.
I was thinking for the vascular component. Is there any evidence that what you're doing is actually clearing out a slightly clogged blood vessel?
No, I don't think so. I think you're just using it as an analgesic or anti-inflammatory.
Fantastic. And are there any precipitants, either in this acute or perhaps more often in the chronic setting, for migraine that we should be aware of that aren't kind of all that much at the top of the medical literature?
I think there are probably a huge range of precipitants, and this is where it comes into being people actually being able to analyse what is going on. Headache diaries are very effective for that, but they do take, you know, a bit more time and a relationship between the doctor and the patient to get them to actually adhere to doing a diary for perhaps a few months. But the things that come to mind are very much, you know, dietary. Classic things like the red wine, and, you know, most people know about sort of coffee and those types of things, but perhaps more insidious, just a poor diet generally, and this may happen for a lot of people, a lot of carbohydrates. Interestingly enough, you know, simple carbohydrates, white sugar, white flour, things like that, donuts, what people crave when they have headaches. So it's quite interesting that many of my patients will say, I just want to eat a donut when I've got a migraine coming on, because there is some evidence that at the time of the acute pain actually settles it down a bit.
But if they live on donuts, then they're going to get more migraines. They're going to get
the rebound headache in the same way as they might from medication. But certainly, dietary things like people in jobs that are stressful and might be poor posture. So the combination of the poor posture and the stress of the job and working, I have many people with headaches that tension into migraine that sit at a computer for long hours. You know, that's not rocket science. Unfortunately, getting people to change their behaviours often is rocket science, or feels like it. So there are a lot of those precipitating factors, but yeah, I have some patients that have them when they relax. So it's quite a classic thing of, you know, they're working all week or they'll be running around after the family, and then at the weekend they're absolutely holed up in bed with a severe headache. So the thing that I work a lot with people is trying to look at, what's the balance between, how much activity they do and how much rest that they get. And even short rests during the day can have an effect on tension headache building up because of the nervous system and the sort of muscular tension that's happening. So, there's such a wide range of things that can precipitate that actually getting someone's headache signature, their personal history and why the headache develops is, I think, from my experience, one of the most important things that can be done, but would need probably GPs to have a double appointment a couple of times with people initially to get that happening.
So how would you start approaching that, and particularly for something like a chronic migraine sufferer where you've got that vascular component as well as that muscle tension component? How do you start tackling it?
Well, firstly, and I mean from my point of view, I think education is really important. I think the doctor taking the headache seriously and saying, you have a problem here that we really need to give you education on, and not just seeing it as, well, this is something that the patient can't do anything about, because often patients do feel helpless. They do feel that medication is the only answer. They've got to keep doing what they're doing in their life. They're often stressed and busy. So I think whether it's a therapist or a doctor taking it serious, saying there are other ways we can look at this. And it may take time for the person to buy that, but it is useful to be able to say, and this is what's happening when you get a migraine. This is what's happening, how a tension headache can turn into a migraine. So most patients, and we've got evidence of that with chronic pain management, respond very well to some simple basic education on what is happening and what other things might be helpful to them. So talking it through, and that's where giving it time, taking it as a serious condition, not as a, something, because the patient often is just saying, I'm getting these headaches, I've just got to get on with it. Somehow I'm a second-class citizen because I've got these headaches and I need to just work harder take a tablet and get on with life. And by the doctor or therapist taking it seriously, they can actually go, I do have a problem that needs to be addressed here. I think that's very important.
When you're talking about takes time, my experience with these patients is it takes a lot of time. What sort of time scale are you talking about?
I think if someone is a severely chronic headache sufferer over many years, you might be working with them for a year or more before you get a change in behaviour. But I would say don't give up. I've often thought this person is just not going to get anywhere, and then we get somewhere significantly. And I think it's being with the patient, and you're constantly giving the message that there are other ways to manage this other than medication. I would say also that the information about overuse, medication overuse headaches is something that most people do not hear, and I think that needs to change radically.
And we'll hold that discussion there for a moment. Jane Muirhead is an occupational therapist from Pain Care in Fremantle. She joined us to discuss the environmental factors that contribute to headaches and what can be done about them.
Headache is a huge problem worldwide, estimated by the World Health Organization to affect 1 in 2 people. So that's half of the world's population will be affected by headaches. So obviously it's a problem that as health professionals we're going to come across a lot in our work. Some of the reasons for headaches are obviously, severe and worrying, but many of them are everyday occurrences that can be alleviated with some practical advice. One of the things that I deal with a lot at Pain Care is people in pain for postural reasons. Posture can be a big driver of headaches and can easily be overlooked because people get into habits. One of them, of course, is the computer screen and working at a computer. I often talk to people about how long they're spending on computers, and it's shocking that people will be on for hours at a time in their work without taking breaks. As you can see here, Bronwyn is modelling for me actually a type of posture that is very common and will bring on headaches in many people, which is slightly forward, the head poked back, but the cervical spine is actually quite compressed and the shoulders are rounded. And that can actually put pressure on the cervical nerves and cause tension type headaches, along with staring at a screen for long periods of time, which can cause the eyes to be rather strained. So people can often be getting headaches from this simply sitting for long periods. The important thing here is to actually get people to change position, move. It sounds simple, but an hour of sitting is a maximum, and one thing that GPs can discuss with people is how long are you spending at the computer without actually standing up and moving. The other thing is there's some very simple stretches that you can go through with people that can help to alleviate neck tension and thus alleviate tension type headaches. So if I turn you around, Bronwyn, one of them that's very effective is a position where put your finger on your chin, push your chin in so that you're giving yourself a little bit of a double chin. That alleviates tension on the back of the neck. And then moving the head gently to the left to a point that's comfortable, back to the centre, and back again the other way to the right. And that can be done 2 or 3 times and several times during the working day as well when people notice neck tension. Another one that's really effective and very simple is a simple chair twist, which is just basically, Bronwyn, hold onto the side of the chair with both hands. You may want to just push out a little bit there, this hand coming over, and turn yourself round to the left-hand side a little bit. So your whole body is coming round, back to the centre, both hands on your knees, and then round to the other side. So a simple chair twist with the head turning round, again to comfort level so that the person isn't straining themselves. That's a very effective way. And then another one is simply just bracing against the chair and pulling the shoulders backwards. So just bracing back and just gently pushing the shoulders back. And that counteracts that poke neck position. All of these things, if done regularly, can make a lot of difference to the tension that builds up in the neck over postural issues. So those are very simple things that can be taught in a short consult to people if there is a sense that they're getting postural headaches from sitting. Another form of sitting that is very problematic is what I call the TV pose. That people slouch on the sofa, and this isn't the best chair to illustrate it, but Bronwyn, if you want to just slouch down onto your bottom and sort of sit there with your head poking forward, a lot of people will get into this posture on their sofas, often again for long periods of time, watching a film, watching television, and will get very uncomfortable. So the same issues apply in terms of posture, and just getting people to actually think about sitting straight onto the television, maybe with a cushion behind them, taking regular breaks from the television. Nobody really likes to watch the ads, so it's a good time to go and make a cup of tea. Such simple advice, but it actually can work for postural headaches really well. Another thing that can really drive pain in the shoulder and up into the neck is this sort of use of the mouse. So you can see here that Bronwyn is working at an angle and she's pulling on her mouse. I see this all the time, and people often will get headaches on one side or pain in the back of the neck when they're actually working at a twisted angle. And people do that when they're in a hurry, and many people are in a hurry these days. So trying to just make sure that people sit straight. So if we move you in, Bronwyn, sit straight, stay close to the desk, and we don't have an ideal here, but the screen should be at the right eye level for people so that they're actually not looking down and therefore putting strain on the neck. So just talking through people's work, if they're getting work-related headaches, you can often find that's an important thing. Another thing that is often overlooked with headaches is the more complex factors of stress and how that relates to headaches. There's some very good evidence that emotional distress can lead people to trigger migraine headaches, and many types of nebulous headache can be triggered by family stress, by work stress, monetary stress. These things are important to be investigated, and headache is not something that we as a society necessarily take that seriously. However, I would urge that enough time is given in consultations to really address issues that might be driving headaches. What happens in our society is a lot of people just revert to medication. It's a quick fix. I'm working on the computer, like Bronwyn, I'm too busy, I can't stop, I've got this pressure on me, got to go home, kids, husband, and even the ads on television are very much about don't have time for a headache. And yet we have a massive problem with overuse of medications. Early morning headaches, waking up with headaches, it's important to investigate the use of medication in those cases. And some of the solutions can be even just being able to talk through issues, find ways around them, a bit more exercise, a bit more movement at home and work, drinking plenty of water. Dehydration, simple, but a huge driver of headaches. So there are a number of things that GPs, even without an occupational therapy, it's in the community, can start to look into that might help people to move towards changing the way they work with their own headaches. Posture, pacing of activities, are they doing things for too long at a time? Are they drinking enough water? Are they getting enough sleep? And what are the emotional stresses that might be driving headaches in the home, or the workplace, or in their general community life? So I think these are things that are important to think about when someone comes in, as well as the big issue of the overuse of medication that might be going on for these people.
And thanks to Jane for taking the time to speak with us. Let's now return to our discussion.
I thought we'd pick up the discussion where we said we would at the point of analgesic withdrawal headache, which is something that we see occasionally in the GP literature, but doesn't seem to be often kind of discussed with patients or diagnosed. Can you tell us a little bit about what it's like and what causes it, and maybe how you go about tackling it?
It's called medication overuse headache, and it's thought to affect about 1% of the population and 0.5% of adolescents, so it's a big public health problem. And it's defined as chronic headache more than 15 days per month, associated with taking often large amounts of daily analgesics or triptans or both. And
so does the patient start off taking the analgesics for headache, or will this happen if they're taking analgesics, say, for their rheumatoid arthritis or something?
It most commonly develops in patients taking it for headache, for tension headache or migraine. And then they get into a vicious circle of increasing frequency of headache, increasing daily frequency of analgesics, and the headache becomes more severe and more disabling instead of less severe. And patients will present taking large amounts of daily analgesics, their headache's getting worse. And the only way of confirming the diagnosis is to withdraw the analgesics and see if there is actually an improvement in headache, and that confirms that diagnosis.
Gosh, so what do you treat them with for the couple of weeks that they're withdrawing off?
Well, it can be challenging, and of course it is challenging to backtrack completely with medication and to convince a patient who is wedded to the idea that although their headache is evidently not controlled by their daily medication, that they would be much worse if they ceased it. And the same applies with other patients with persistent pain who are dependent on large amounts of analgesics and opiates. And it evidently isn't controlling their pain well, but they're very fearful of being without it, and there's a lot of anxiety and mood disturbance that's feeding into these issues. So if you're going to succeed in withdrawing them, it's very important to convince a patient that their headaches are relating to their medication. And of course, ideally, they should have been warned up front when they were moving towards taking excessive amounts of medication that they were at risk of making their headache worse up front. And I think that's an important message to give patients, that they can, a proportion of patients in this situation will actually become worse if they take daily analgesics and triptans.
So yeah, how would you help them out, Jane?
Well, I'm sorry to sound like I'm harking on about the same thing, but finding out from quite an in-depth study of what the person is doing and how they're behaving is often very helpful. For instance, overuse headaches tend to be more common on waking, overuse medication headaches. And so by getting a diary, you can look at whether the person is getting enough sleep. And also I often add in the cognitive behavioural part of it, which is their mood. You know, there can be underlying issues, psychosocial issues, mood problems, depression, anxiety. And often, as John mentioned earlier, the anxiety around how will I cope? Every day I have this headache. And just grabbing the medication just to get through the day. And I think with people addressing that fear and helping them to perhaps start on, even before they stop taking medication, of giving themselves breaks, of giving themselves time out. Now, I know that's very difficult for people, but sometimes I have people who have some music that they like to listen to, or sit down and have a cup of tea. They're often simple things can really help, but people don't think of them, and they're often too ashamed to talk to them GP. You know, they don't think that their headache should be that much of a problem. So I think the doctor actually eliciting, you know, there are other things that can help with this. It might be quite simple, a walk in the park. I try to get people to have times in what I call, say, a pain-less zone or a pain-free zone, if that's possible, where they get very comfortable. They might put a heat pack on, or they might lie down for a short while with the timer on, so they don't just go to bed for long periods of time. They give themselves things that are supportive to them, that work for them, and that can be different for every person. You know, even for an adolescent or a young person, it'd be cuddling a teddy bear. But they're self-soothing when people are in pain is a very important component of it, and we often don't think of that as being relevant. And I've actually had really good success with people just taking short timed breaks during the day where they rest with a heat pack on in a very comfortable chair and maybe listen to some nice music or a relaxation tape. So some of the solutions...
So the soldier on with Codral isn't really the answer.
Not in the long run, but I think persuading people that that's not the answer can take a while. And so, you know, not having expectations that someone will just immediately stop their medication, that could add more anxiety onto them, which would make the whole situation worse. They'll just start popping the pills and the doctor won't know.
Yeah. And Tony, earlier on before the program, we were talking about the acutely or chronically dehydrated patient and the relationship with migraine. Could you tell us a little bit about that?
Well, that's when we're talking about triggers of migraine, there's the ones that everyone sort of knows about, which are dietary and hormonal, but the one that's increasingly recognised is a water deprivation precipitant. And they don't get dehydrated, you know, they don't get clinically dehydrated. I suppose you can say they get subclinically dehydrated. And they just drink less water than they normally would, and that can often precipitate a headache. It's been known to precipitate migraines, but also it probably precipitates tension. So again, you get that mixed headache that needs treatment.
And so easy, keep the water bottle on the desk and keep slurping.
That is, and that's perhaps why placebo works so well, because placebo often includes IV fluids, you know, in all the studies. And, you know, you just get their dehydration or their subclinical dehydration under control and the headache goes away. And that probably works as well as some of the other stronger medications.
Yeah. And John, we've talked about some of those nice, simple, gentle approaches to headaches. Are there some patients for whom this really doesn't work?
There is a hardcore group of patients with severe migraine who fail to respond adequately to preventative treatment and optimised acute management, and ideally should have accessed appropriate self-management and CBT, although that's unfortunately not widely available. But there is a group who have a very dysfunctional brainstem. That's where migraine is thought to originate, as a sort of instability of the brainstem, generating these migraine episodes. And this group of patients, if they've failed all other management, should be considering interventions such as occipital nerve stimulation, which during the last 10 years has emerged as often a very effective treatment for a very small group of patients who are very disabled.
You know, I've occasionally put occipital nerve blocks in for patients who've got really severely locked up cervicogenic headaches, and they're very effective. But could you talk us through occipital nerve stimulation?
Well,
sounds
you're right.
very tertiary hospital.
You're right to correct me that one of the treatable triggers of severe migraine becoming very chronic and disabling is upper cervical dysfunction and cervicogenic headache. And if you have pre-existing migraine that can be quite mild, and you have an upper cervical injury, a whiplash injury, or basically nociceptive pain from an upper cervical segment dysfunction, and you typically get tenderness over the occipital nerves, then that can move them into a chronic headache state. And treating the upper cervical nerves with local anaesthetic and steroid injection can be very helpful.
Yep.
And treating the upper cervical facet joints with the right sort of physiotherapy and injection treatment can also be very helpful. But if that doesn't work or the effects are very temporary, then they would become candidates for occipital nerve stimulation.
Good. And can you tell us a little bit about that?
Well, this involves placement of an electrode. It's the same equipment that's used for spinal cord stimulation, and this is inserted under the skin over the occipital nerves through an epidural needle. And it's placed for a week, just tied in with a little silk stitch, and the leads are run down with sticky tape down the neck and attached to a device like a TENS machine, which you can walk around with and do normal activities with. And they basically road test it for a week, and if they get more than 50% pain reduction and are able to reduce their medication and become more functional, then that's the criteria for a permanent implant. And many patients will report 70-80% pain reduction when nothing else has worked. And
this is something that just works by loading up the occipital nerves with so many impulses it can't get the pain impulse.
No, it's
through?
working. It's almost certainly working centrally. It's feeding a comfortable electrical tingling is what patients report. It's adjusted to give a comfortable tingling over the back of the head.
Yeah.
And the occipital nerves come from the brainstem.
Yeah.
They come from the trigeminal-cervical complex that goes up to the brainstem. And what you're doing, stimulating these nerves, is to indirectly stimulate the brainstem and to provide a modulating effect on this sort of brainstem instability, which is thought to be the underlying mechanism for migraine. And PET studies have demonstrated in patients with occipital stimulation that you produce quite widespread changes in function in the brainstem and the thalamus and various areas. So it does seem to work on a central nervous system level.
So I always thought that migraines were very much related to vasospasm.
Well, that was the older model. The initiating mechanism and the underlying problem seems to be what's described as a dysmodulation of the brainstem, and then the vascular phenomena and the spreading cortical excitation that has been demonstrated as a sort of secondary epiphenomenon.
Okay, so when we're using a beta blocker or a similar agent, we're actually still getting in at the second step of the migraine, not at the first step.
Well, a lot of these drugs have multiple actions, and it's still poorly understood, I would say, the interaction between the various mechanisms in migraine. But the underlying problem seems to be a central nervous system dysfunction, and that provides a rationale for the effectiveness of occipital nerve stimulation for chronic migraine and occipital neuralgia. Yeah. And it also works for severe cluster headache and the other trigeminal head pain problems. Not trigeminal neuralgia, but the trigeminal autonomic neuralgias, which are these nasty things like cluster and sunct and hemicranial continua, and those are other exotic things that neurologists diagnose.
I was going to say, they sound pretty exotic. The cluster headache is the tearing and the sweating just on the one side of the face, isn't it?
It's always just clustered around
headache?
one eye, and it's episodic, and it can go, patients can go for quite long periods without having any problems at all, and then they'll go through a period where they have recurrent, very severe headaches just around the eye with tearing of the eye, and they'll typically be wakened at night, is when it frequently occurs. And it can respond to a number of treatments, oxygen, preventative treatments, anti-epileptic drugs, similar treatments to migraine, in fact. But there's a group of patients where nothing works very well. Yeah.
Now that cluster headache sounds a little bit like the thunderclap headache that you were talking about, Tony. Is it obviously something somewhat different?
Yes, the benign thunderclap headaches are the ones that we sort of diagnose out of exclusion, and they present very much like subarachnoid. So often with a sudden onset of very severe headache in someone who's never had it before, and really we exclude a subarachnoid first. But the cluster headaches often are a bit more classical. The patients often know that they have clusters, and they present with the parasympathetic signs around the eye. And as John said, we treat it with oxygen. That doesn't really help that much for some patients. We treat them as migraines mostly. The other things you can try are intranasal anaesthetics. So we sort of spray some lignocaine spray up their nose. And that sometimes
How
helps.
does that work?
No.
What you're aiming to do is anaesthetise the sphenopalatine ganglion, which is this sort of autonomic relay centre that lies at the back of the nose, under the ethmoid plates.
So get some cofenylcaine forte up there.
Well, you lie on your back and you trickle local anaesthetic, 1% lignocaine or marcaine, down the nose, and it gathers in the back of your throat, and it then seeps through to the sphenopalatine ganglion. And it certainly can help a proportion of patients with recurrent cluster headaches.
Well, that's ingenious.
I was
That's
really
something that I've never heard of.
I was really interested in the stimulator, because in ED studies, classically there's a greater occipital neuralgic patient who comes in and they're tender over the nerve and they get shooting pain. And when we inject them, the pain goes away. And we think it's fantastic. But there's ED studies which have also injected around the neck, not specifically over the greater occipital nerve. And there's good effects for migraines, tensions, clusters, and cervicogenic. And they've injected, not anaesthetic, they've injected saline, and it causes the same sort of thing. So it is, very strange that you can sort of stimulate, non-specifically stimulate that area, and it can affect a whole number of various headaches.
There are lots of ways of stimulating the nervous system, and chiropractors, physios, injection treatment, they're all feeding input into the nervous system in a territory which has access to the brainstem.
Yeah.
Indirectly. So I think that explains why a lot of different approaches can have similar helpful effects for some of these patients.
Do you think that's how acupuncture and some of these other complementary things work?
Well, they're all stimulating the nervous system and producing changes in the nervous system.
Of course, there's the Botox injections. It's a whole new use for Botox, which I think in the States they actually have clinics that people go to have Botox injected into areas that trigger very easily, because a lot of headache sufferers have hypersensitivity and tiny changes in the sort of neuromuscular system with stress. So they will respond differently to stresses that might be quite minor for other people, but their sort of the cervicomuscular area will be very, very sensitised and will respond very quickly. And that's where, a whole lot of these things, as John's saying, feed into the nervous system, as do ways that people can learn to relax themselves. And, there's a range of ways that can be used. Unfortunately, the self-management often take more dedication and more time to get happening, so they're not a quick fix.
No, they're not. Jane, there are some other things that the patients sometimes exhibit and sometimes don't realise, and sometimes do, things like they call it eye strain, which often is just too many hours in front of a computer or a desk, and tooth grinding. Do you have an approach to any of those?
I don't actually see a lot of tooth grinders, whether not overt ones, whether they're going more through sort of dental therapy. I don't know about you, John. Do you see a lot of
I
tooth
don't.
grinders?
There are now dental specialists who deal with those sorts of problems, bruxism and related sleep disturbance and temporomandibular joint syndromes and facial pain and headache. They all overlap, and interestingly, they increasingly are considered to be disorders of central nervous system dysfunction rather than peripheral pathology.
Interestingly enough, I have come across some of those in my other role was as an OT in acute psychiatry, and people with trauma, and there is a greater link between early traumas and chronic pain developing, but certainly people who have bad sleep with nightmares and things that are waking up with severe neck and head pains, probably because actually they may even be thrashing around in bed. So, even those considerations, it's a very wide net when you actually start to look at how headaches develop. And, there is this link with depression and with trauma, with chronic pain. And of course, headache is a big part of that.
Now, we do see quite a lot of patients with bitemporal pain. And whilst I think a fair few of them are either tooth grinders or tooth clenchers, and I'm now increasingly seeing patients who've been put on an SSRI and who've started to actually clench for whatever reason. seems to be a not very well written up side effect. But you do sometimes get some other things, and probably also in the rarities category are the patients with temporal arteritis. Is that a headache type thing, Tony, with the temporal arteritis?
It's a systemic presentation. So a headache is just one of the symptoms that they present with. So often they don't feel well for often a few months. They just feel a bit lethargic and a bit achy. And may have some weight loss, and they might have some other symptoms which are a bit more classical of giant cell arteritis. So they might have a very hypersensitive scalp. So when they sort of brush their hair, it's sort of sore, and they get the jaw claudication, so that when they chew crusty bread, it sort of their jaw aches, and they're all sort of symptoms of a vasculitis and ischemia, and they're usually older. So almost all of them are going to be over 60. And the problem is that the vasculitis can cause ischemia and occlusion of vessels, usually the smaller or medium-sized arteries, so the ophthalmic artery. So going blind is one of the main dangers, but they can also have strokes. So if an older patient presents with a headache, we would do an ESR to try and exclude temporal arteritis as a routine if it's a new headache in an older person.
Yeah. How many of them do actually have the classic hose-like tender artery?
Well, my experience is very limited. Even though we see lots of headaches, I've probably diagnosed temporal arteritis 3 times. So it's still a very rare condition. So I can't really tell you if they have got those symptoms. They might happen more in patients who have a more chronic presentation, and so they get the vasculitic changes around those arteries.
And John, you were talking earlier about patients who have polymyalgia rheumatica and who may present with headache. Can you just run us briefly through that?
Yes, well, these patients are again middle-aged, and they present with neck and shoulder girdle pain, and sometimes lumbar and pelvic girdle region pain, and it's a fairly continuous aching pain, and has an inflammatory component. And they normally find their way to rheumatologists, I would say, rather than chronic pain specialists. And they respond to anti-inflammatory and steroidal medication.
Steroids. So basically we just keep a high index of suspicion for all other things and bite the bullet and take on very chronic management. Jane, just before we completely wind, could you tell me, country occupational therapists, do they have a great deal of training or experience with headache management?
It would vary immensely, but generally there are very few occupational therapists who work in chronic pain. They're quite a small handful. I think there's a vast need for more training. Occupational therapists, it's a little plug for us, because they cover both the physical side of things and the psychological, I think a very good breed, if you like, for working with chronic pain, because we can look at those physical aspects like posture and, someone's just general physical, ailments, and also look at what's going on psychologically and marry the two together. And in those that group of chronic patients, that's really, really important. There are some areas that GPs can, or occupational therapists can access off the web. There's Headache Australia that has diaries that can be downloaded, headache diaries, as is the World Headache Alliance and the International Headache Society, and they all have quite a lot of self-help pamphlets that are for free. So they're useful resources, but I think there's a great need for further training and just for more allied health professionals out in the country to assist GPs with this and many other difficult problems they face.
Fabulous. And from the other two, any final take-home messages for the doctors?
Well, from my perspective, I think, for the acute headache, you have to try and rule out the sinister causes, whether they're intracranial causes, local causes or systemic causes. And if you have, then the International Headache Society actually has an algorithm of diagnosing headache. So you rule out the sinister causes and the secondary causes, and then if it's a cluster or a tension or a migraine, basically you treat them as a combination headache.
Fabulous. And John?
Yes, I think with chronic headache, the important thing is to make a diagnosis of migraine, which is a common condition if that's the cause of their recurrent pain, and to take a preventative approach to medication overuse headaches. So warn patients up front that they mustn't move into taking daily analgesics if their migraines are becoming more frequent and disabling, that they should go on to preventative medication, and that they should be accessing adequate self-management and treating upper cervical factors that could be aggravating their migraine or producing occipital neuralgia. All those factors should be identified systematically.
Fabulous.
Rather than allowing patients to just take more and more over-the-counter analgesics, which is now recognised to be very counterproductive.
Fabulous. Well, thank you all very much for joining us today, and I hope you've enjoyed it.
Thank you.
Thank you, Maura.
Thanks once again to our guests tonight, Professor Tony Celenza, Dr. John Salmon and Jane Muirhead. That's all we have time for tonight. Remember, this program or any of our programs going back to 2008 are available to access on our website, ruralhealthwest.com.au, and full sets of the 2009 and 10 DVDs are also currently available for just $80 for a set of 10 programs. To order, simply call Rural Health West reception on 08 6389 4500. We're back again on the 3rd of May with a program focusing on farmers' health. Thanks for joining us tonight. I'm Jerry Gannon. Good night.